Now we're going to hear from Tony Bell, who's Chief Executive of Chelsea and Westminster NHS Foundation Trust, about where local perspective on ACOs.
Okay, thanks, Nigel. Well, I've been asked to give a local perspective, and I think what I'd just ask you to do is accept that all of what you've so far heard is the context in which this is happening. What I'm offering here is a view from the other end almost, which is how might you make this happen, and a local perspective from the point of view of ACOs. I think it's important to say right at the outset that from our point of view, there were some beliefs that we had, and I think for those of you who can read those, the first one of those is looking at the acute hospital domain, looking at the patient experience. We had a feeling certainly a year ago that we could do better. Why has flow through hospital become such an issue? Why has getting people out become so difficult and such a challenge? And is this the best way and the best experience we could organise? We felt not. And when we look forward in the context of this integrated working, it's clear that if you look at this as a supply chain, there are a number of people across the system, including the acute hospital, that have to collaborate and collaborate in a very integrated way. You can't do this, you can't improve that experience by simply focusing in one area only. So that was very much the basis on which we started to explore the notion of accountable care organisations, which we'd heard about certainly in the US and also in Europe, and we've got partners with us today who are going to speak on this platform from both of those. And I'm going to refer to them in a minute because they've been an important part in our learning about if you're part of this system trying to deliver in that supply chain, then what is it you need to know and how does your mindset need to probably change? So I think that the other thing that is also clear is that in the current system, we all know that we are dealing with a growing elderly population, increasing burden of disease, increasing demand for health service, and in most countries, in most cases, limited and diminishing resource. We've got less people economically active to support that growing number of people who are dependent. So something has to change. We can't carry on as we are. It's clear to me, and I think it's clear to many, that the payment by results system that we have of rewarding people for admissions and activity has to change. The question is what to and how. And reference has been made to the capitated payment system. And again, it seems to be quite sensible, really, that if you have a spend per head of population in any population group, then you'd expect that to be the spend within which the whole health and social care need gets met. And it is the job of the people in that supply chain to make sure they live within that resource and get the best value they can from it. And there is their incentive, I think, for making sure that they act in a collaborative way. Too often, we act in a very competitive way and in a way that disadvantages one party to the gain of another. And that's why on this slide, what you can see, as I'm saying, is actually the contract is helpful at one level, but totally unhelpful in transformation. The contract can underpin some important principles in which you're trying to work together, but as a means of actually transforming how you deliver care or driving efficiency, it simply doesn't do it. If you want to change behaviour, then in our view, we had to move to a different system where you got people together. And this slide really just points out the fact that we all know we've got increasing demand on limited resources. And in fact, in the UK health system to date, we've got very limited choices. A&E departments are filling up and frequently full because people's choices are relatively limited. The other thing that's clear when we started to look at this is that if you segment the population, you start to look at who comes in the most times and who actually have the chronic conditions in your population, you can begin to predict actually where you need to intervene. But intervening in the A&E department is too late. Intervening before they got ill is where we all want to be. Keeping people well should be part of a hospital's remit because it's part of the health system. and we need to move away from the sickness model that we have. So this slide simply points out that all too often, we have avoidable activity going on. So what we did was we started to look at this and say, well, let's not just look at how we get through the next contracting year as a hospital. Let's look at how we deal with the next 10 years. How does this organisation need to change? Very much in the context you've heard from Thurza and other speakers this morning. What we simply did was focus down on our local population. That's not everyone that we treat. And in the case of Chelsea and Westminster, just to give you an idea, it's about a 500-bed operation with 3,500 staff and about 360 million turnover. So, it's a medium-sized hospital. It's not massive, and it has some specialties in it, and it has a lot of basic services, including A&E. What we did was start to talk to our two most local clinical care groups, and particularly GPs in those clinical care groups, and started to establish a dialogue with the two community trusts that we also work with on this population group. So essentially, we were looking at a population probably in the region of 150 to 200,000 people. North West London is about 2 million people, so this is a small segment, even of our catchment population. But what I've found out so far is that what matters is being able to talk to people about how you address that together. And so the organisations listed there included the two community trusts at the CLCH and CNWL. One of the CNWL is also a mental health provider, Hammersmith and Fulham GPs, and also Kensington and Chelsea GPs. They account for some of our biggest spend, and we got that group together and formed a team that have started to examine, well, if you use, before we had the toolkit you're talking about, if you just use the principles of segmenting the population, as that triangle shows, as a lot of you will do, you can segment it by a number of different strata, but how do you understand this population we're dealing with, other than what simply hits hospital or doesn't? We also put a bit of resource into a small team that we pulled together, the ACO team. We realised we needed some public health input, we needed to put some strategy work into that, we needed to put some dedicated time into trying to understand how did we move into this new arena. We also did a couple of really important things, I think. One was to visit Valencia in Spain and to look at their experience of developing this type of collaborative arrangement, whole system arrangement with GPs, with their community services, with the hospital, all joined up, operating under one capitated payment system. And you're going to hear from their Chief Executive, Santiago, today about their experience. For any of you Lean fans out there, you'll know what I mean when I say there's a saying in Lean that when things aren't working well, you go look-see, no matter who you are. And that's a very good principle, I would say, about where we're trying to move to now. We can't plan this from a desk. Many of us need to go look and see what are other systems doing who have been there, who are experiencing this. And I would recommend Valencia, who probably need to open a visitor centre, which will keep Mercedes busy for a long time. But we are very grateful for the way they hosted us and were very open and talked to us. And so we took some of our GPs, we took some of our community trusts, we took a non-executive director and myself off to Valencia for 2 days, and we absolutely interrogated them and their system to understand it. And I think my slide, there we go. Now, one of the important things I will just say, which I know Santiago will refer to, is they have a common information system between them that they've built. We learned from that. We learned the value of it, and that's not to say that you have to start designing from a blank sheet of paper, but you do come to realise the sooner you can have a single patient record or something by which you can both view what you're talking about, including the patient, the better. They manage their referral pathways, and they manage the protocols on which people get referred and what it is they have to have had done before they get referred. And I won't steal Santiago's thunder in telling you how successful that is, but a common information link is really important in the development of this system moving forward. I think that's a powerful change agent, and it really helps clinicians understand what it is they need to do to get it right. So that was just to prove the fact that we all went there and there was sunshine on the day, and we had a good time. Now, the other thing we importantly did, I think, and this was really down to my Director of Strategy at the time, Axel Heitmüller, who was here in the audience and is now working with the Academic Health Science Network, Imperial Healthcare Partners, was working in Chelsea and Westminster at the time, and introduced me to another colleague, a friend who's here today, Dennis Cortese from the Mayo Clinic. We started a dialogue over the phone with Dennis, who really has been an inspiration and a great guide. More than that, as someone who's looking at a range of ACOs across the States, different shapes, different sizes, different focus, but all with a common purpose. And he sent across his researcher, Natalie Landman, who joined us in one of our ACO meetings to just walk us through, so what are you trying to be? Where are you trying to get to? What are you trying to achieve? And I think that was a really useful conversation to have early on between these partners. And I think that, you know, she gave us a definition that they like, and I would just ask you to take a look at these principles if you want, because as I read them, and I think as I've reflected on them, I think actually they're all pretty non-negotiable, and you need to have all of them present. It's important to have a coordinated continuum of services from a patient experience point of view, from an efficiency point of view. It's important to focus on a population. How else are you going to get this improvement or measure what the improvement is? And it's clinically and fiscally accountable for the outcomes we deliver. That's the whole system population. It's not one element of it. The big issue we have is that if you make a change in one place, the benefit accrues in another. So the only way to deal with that is to actually change the way you commission with this resource, and indeed who owns the resource. So we'd already taken a step mentally in thinking perhaps we should just imagine we all own the resource of, you know, £1,200 per head or whatever the capitated payment is, rather than thinking it belongs to the commissioners and we just do what we get told to do through a contract. This is a different mindset, which says we have a long-term problem here. How are we going to address it all together in a way that you get value for money from that payment per head, from your hospital, from your primary care services, etc. So, I think the key attributes of the high-value care and integrated systems have been rehearsed already. Now, I'm not going to go through these. But I think it's fairly clear to people that integrating care is necessary in a system that is going to be accountable for the outcomes and the delivery within a financial envelope. But the two are not one and the same. Simply integrating care does not turn you into an accountable care group or organisation. That requires a different approach to the money and a different approach to the responsibility. There's got to be an incentive for everyone here to work differently together, not just one element of the system. So, obviously, the shared data derived from the patient record, clinical leadership is critical in that. We learnt that early on. I think it's why, you know, this group has contained more clinicians than it has managers from different parts of the system. One of the biggest things I think we saw in Valentia was the fact that this was getting to be doable because it was small enough to not be overly complicated in terms of the relationships that needed to be managed. And you will know, like I know, over the years, it's people and relationships that make things happen. It's not contracts, it's not even information systems. It's people and relationships that change things. What we need here is sufficient number of people with a big enough population that isn't overly complex and has a small enough number of people involved to have relationships that become personal, informed, trusting, in which information sharing is easy, and in which taking some risks is also easy. You can't do that simply through the contract management process. It needs management support, absolutely. You do need to balance quick wins with long-term gains. It's not all about this will be better in 10 years' time. I think you do have to prove to yourself things There are things you can work on today that will improve things for this year. But I just became convinced from what we heard from Natalie, from Dennis, from what we'd understood in Valencia and in looking at our own system, this issue of focusing down, not making it too big to take the first step, proving the concept and then developing at scale because you've proven you can work in that way is the way to go. If you start with big scale all at once, you overcomplicate issues and people lose their relativity in it. They can't relate to it. They don't really understand how this affects me, my hospital, my GP surgery today, this week, or next year. This is in the slide pack, which I hope you'll have access to. I think you will, but it just describes the link between the integrated care part of our ACO model and the accountable care philosophy. Also, that we've started this process of looking at, so what are the proportion of patients we're seeing? And it probably won't surprise you to know, it may do, it did me to start with, that heart failure is probably our biggest single diagnosis on admission. And the next thing you need to know is that's not the reason the person came. So you need to be aware of what hospital information systems or any information system tells you. Simply taking out the data doesn't help you into understanding what you would have done to have avoided a number of those admissions. It simply is a log of what is the diagnosis on admission. We've also looked at the patients on our long-term care conditions register. And again, it's a really helpful insight to begin to build a picture of this local population. And if you can begin to act differently for 150 or 200,000 people, then you'll begin to really shift how the whole system works and thinks about how those patients access care. And as you've heard, there's no shortage of information. There's no shortage of people who you can go and talk to about integrated care and accountable care. But the one thing that I've, I suppose, learned through my own reading about this, whether you're listening to Michael Porter or you're listening to people that we've heard this morning, is that you need to start, make a start somewhere. You need to put policy into practice. And to do that, you've got to start by getting a group of people round a table, talking together about a population they can relate to and about changes they're prepared to make together. So you've seen the time frame. We're looking forward to the fact that we now have a toolkit, we have a context within which we're operating, and I'm very hopeful that someone will say and take the risk on the fact that this partnership is one that'll be worth experimenting with for the next 12 months to see if we can actually produce some results on a very focused population and see how that begins to transform the care we deliver. So there's the summary. Volume-based incentives don't work. They're not fit for purpose for the future. We shouldn't be trying to drag people through care systems as fast as we can go, which is a poor experience with poor outcomes generally. We need to work together. Everyone needs to feel an equal partner in that system. This is not a contract relationship issue. This is about solving a big problem together. It requires a different mindset. We have one set of money we can spend once, and shunting it around actually is not going to help. Scale and resilience in primary care is something we've learned. We might assume because we work in bigger organisations is automatically there, but I certainly learned here that primary care itself needs to develop some scale to feel comfortable at this table. And we need to help them, and I think they need to let us help them. But I think we need to recognise this is not the behaviour that we've had for the last 10 years. This is a new set of behaviours. And finally, start with the end in mind. It's a very good thing that someone reminded me of some years ago, which is have it in mind what it is you're trying to achieve, because you need to revisit that together as a group constantly. I think we need to not only have improved the patient experience, but to have re-engineered the healthcare system in a more productive way for the future at the end of this, we will probably not have the hospital we've got as it's titled now, and we probably won't have the primary care surgeries we've got as they're titled now. Maybe we'll have something different. It's not important. What we're trying to do together is improve health outcomes and do that in a way that actually delivers better value, better efficiency. And finally, which we all know, Marshall Goldsmith said in his book, you know, what got you here won't get you there. And I listened to Michael Porter on a stage in London here just last week saying pretty much the same, which is, you know, most of the bits of furniture we've got are not actually going to help us tackle this problem for the future. So we need to seriously and radically rethink the system and how it needs to operate together. And I hope very much that the North West London integrated pilot will be an opportunity to test that out and put us into that very different stream where we're working to one goal. That's it.
Thank you, Jamie.
Thank you.